Assalamu alaikum. Welcome everyone on board. Um, Unfortunately, I was busy in last 2 days, so I couldn't take class. So we had started discussing some exam-oriented scenarios or some important points about respiratory system. So we had discussed asthma. So we will continue from where we left. Uh, I will just try to revise few of the things which we discussed. Generally, the scenarios which are being asked from this topic usually are like just a second, please. Yes, so usually the scenarios which we get, um, it can be in a long case like or in a table viva. Usually they are either like COPD or asthma, or there may be a long case of tuberculosis, or respiratory scenarios will be related to the complications. Okay, so either it is like in an as an ICU, or you can say ER, or any intra-op. Okay, or you can say there will be some post-op. So usually the scenarios will be the other will be restrictive. Okay, and then one portion will be which will be related to thoracic. Okay, but usually some of the points are are common. So whether with reference to, of course, the respiratory um, scenarios, some of them are related to like they will be covered in other um chapters, like we discussed upper airway obstruction in detail in our pediatric discussion. Okay, so we have covered some of the points. So lower airway obstruction, so if it is uh, reversible, so we can say it is like asthma. So we as discussed some points about asthma. Okay, and if the asthma is not reversible, and now there is destruction, fibrosis, or there is damage to the airway, and so it is leading towards, because asthma can lead to COPD, or you can say it has some association, or you can say that the concept of asthma is there in COPD as well. So in COPD there is component of reversible airway obstruction. Okay, so and, it does not mean that any asthmatic patient can become COPD. So actually the phenomena which is there in COPD has some reversible component. Okay, so this is just a conceptual thing. So I hope you understand. So COPD, if we will go in a slightly different way. So what, Zishan, can you just think that if you just listen that the patient you are having is having COPD. So what do you think? What things come into your mind can which will be of importance? Zishan, are you here?
Uh, yes, sir. Yes, sir.
So what do you think that when you think about COPD, what are important things which come into your mind as an anesthetist? Yes, please.
Hello.
Yes, yes.
Yes, sir. Sir, in patient with COPD, for being an anesthetist, we have to first assess the severity of the disease, rule out
Okay.
the active infection, and medication history, patient medication history, uh, and patient current smoking history, and the associative end organ damage due to the exacerbation of the COPD on other and other multi-systems. So we have to rule out those disease on our history examination and relevant investigations, sir, before
So
in anesthesia for
this
anesthesia.
is this is you are telling the evaluation. So as an
Yes, sir.
anesthetist, when you are anesthetizing a patient with COPD, okay, what do you think, like what things, what problems you can face? I rephrase my question.
Sir, while anesthesia patient with COPD, uh, patient could go in exacerbation. There could be a bronchospasm. A patient
Okay,
could have a
just a second.
decreased FiO2.
Exacerbation, exacerbation is one point. Bronchospasm is another point. What else?
Sir, patient could have systemic serious serious complications in the form of arrhythmias and may have patient can have heart failure, sir. So that can also be associated with COPD, sir.
Okay, what else?
The patient could have pulmonary edema, increased chances of pulmonary edema, increased chances of pulmonary embolism, increased chances of post-op pneumonia,
Okay,
increased
just a
chances
second.
of respiratory.
Just a pulmonary embolism. Okay. So post pulmonary embolism. Okay. We will discuss each and everything how it is related. So pulmonary embolism, pulmonary edema, bronchospasm, heart failure, post-operative. What you are saying? Post-operative,
Sir, patient can have post-op respiratory type 1 or type 2 respiratory failure, sir.
post-op respiratory failure. Okay. What else?
And increased chances of pneumonia, increased
So
chances
that
of
will
pneumonia.
okay.
Pneumothorax.
So pneumothorax. Very good. Okay.
So
So
emphysema.
emphysema will lead to like okay, emphysematous bulle can rupture and pneumothorax will occur. Okay. So now you think something more. Think about medications. So any concerns with reference to medication?
Yes, sir. These patients are on. These patient can be on steroids. So all the concern related
Steroid,
to the steroids, sir.
steroid
Yes, sir.
replacement. Okay,
Steroid replacement.
stress replacement. So this is one thing. What else medications can affect our anesthesia management? Okay, first of all,
Sir, if patient
just
are on
consider what are the medications these patients are on usually. One is a steroid. What else?
Beta agonist.
Beta agonist. What else?
The mast cell stabilizers, ipratropium bromide.
Protropium bromide in this is more in asthma. Okay, mast cell stabilizer. But this is less important in COPD. What else? Think when you think when you say beta agonist, you can think about other bronchodilators. Okay, so phosphodiesterase inhibitors, so aminophylline, theophylline. Okay, so when you said heart failure, so anti-heart failure medications. Okay, so diuretics and vasodilators. What has happened? Vasodilators. Okay, so just briefly, steroid. We told the all the systemic effects of steroids. So you can someone tell what are the systemic effects of steroids in a summary? Because in the
uh,
Viva or you just want to think, you have to be very concise. And that's what I say. This is what I tell you all every now and then, that you should have prepared answers for certain things. So now you spoke out steroids, so you immediately you should be thinking what will be the immediate effects, common side effect, common problems in a steroid patient. So what will, how
sir,
can you tell?
sir,
Yes.
common problem in a patient taking long-term steroids are immune suppression, increased chances of osteoporosis, abnormal glucose metabolism giving rise to hyperglycemia, increased chances of ulcers in the stomach, delayed wound healing, and then there
Okay.
is adrenal suppression.
Okay, you are missing
Glucose
something.
intolerance.
Glucose intolerance is there, hyperglycemia. What about obesity?
Obesity. Yes, sir.
Okay, that's this for lemon and drumstick. So obesity, if obesity is also a problem which can be there in patient puffy face. Okay, so so obesity is another thing which you should be thinking. So whenever obesity will be there, there may be OSA. So OSA will like they are coming in package a number of times. Okay, so you can chalk out. So and you have to give steroid replacement. So you should know how to replace the steroids. There is a a guideline for it. Beta 2 agonist, there may be hypokalemia, tachycardia, which can affect mast cell stabilizer as a and leukotriene antagonists. They are for maintenance. Phosphodiesterase inhibitor, again there may be arrhythmias. Okay, and they are arrhythmogenic, aminophylline or theophylline and things like that. And the diuretics, so you can say speak out separately. Hypokalemia, like electrolyte imbalance, volume depletion. Okay, vasodilators, they also have side effects. So if it is AC inhibitors or ARBs, you can expect sudden fall in blood pressure. Okay. So these are the thing. And the rest, which I was just because, remember one thing, everything is written in the books. The purpose of our discussion is just to have thought provoking things. Okay. So you should just, because usually the practical oriented things are not written everywhere or written in the books, but you in the exam when they are asking you, it's sometime it is difficult to extract. Okay, so COPD patient, you can divide broadly that COPD patient may be receiving general anesthesia, may be receiving regional anesthesia, and even COPD patient can create a problem even if the patient is not receiving any anesthesia, because that patient will have orthopnea. Okay, so patient is not able to lie flat. So maybe you are evaluating a patient with COPD and you clear the patient for eye surgery. Okay, and now you are in trouble because you pissed that patient is not able to lie flat on the bed. So how will they do the surgery? Because usually their bed is in a different position. Okay, so COPD patient, it's very important to analyze. Of course, another point we will discuss now, we will expand our topic. So another point with reference to COPD is that how to optimize a patient with COPD. What will be the things which you can use preoperatively to get a better outcome in a patient with COPD? Yes,
There's cessation of smoking, first of all.
smoking cessation. What else?
Good compliance with the medications which the
Well,
patient is using.
what medications?
Nebulization.
Nebulizations. So try to be very specific, like steroid. We can give a course of steroids. Okay, this is one. Smoking cessation, bronchodilators, nebulization with the bronchodilators or steroids. What else?
So if the patient has comorbidities like hypertension, controlled hypertension, if the patient has cardiac involvement, then the symptoms accordingly, sir. If the patient has pulmonary edema, diurese the patient.
Okay, we can have antibiotics for a recent infection. Okay, think something more common. What about Zishan? You want to add incentive spirometry?
Yes, sir. Regular chest physiotherapy and chest rehabilitation and incentive spirometry, sir.
Incentive spirometry, postural drainage of the secretion. Okay. Maybe if the patient has some pleural effusion, so pleural effusion tap. Okay.
Mucolytics.
Mucolytics, very good. So mucolytics and acetylcysteine. So whenever they are doing postural drainage, so postural drainage, chest physio, and this N-acetylcysteine is a combo. Okay. So, and this you can do relatively, you can, like you have a patient, COPD, coming for any surgery, you can have these things. And of course, you will say that I will refer the patient to pulmonologist and probably they can do these things. And even if the patient is going for an emergency surgery, like not real emergency surgery, you can say urgent surgery. So immediately you can give a lot of things. You can give a steroid shot. It will prevent the post-operative complications a little bit. You can, if anything you find immediately, you can do some of the things. Okay. Uh, so when you were saying, you said about pulmonary edema. So how pulmonary edema can occur in a patient with COPD? Yes, Ishan, you said this. So can you explain? Because in the exam, whatever you are saying, you need to explain. Yes, Ishan.
Yes. Sir, this patient can have a chronic hypoxia, which could lead to chronic pulmonary vasoconstriction. Sir, these patient can have chronic hypoxia, sir, which can lead to pulmonary vasoconstriction, and chronic pulmonary vasoconstriction will lead to increased pulmonary hypertension and right heart failure. When there is right heart failure and increased vasoconstriction, and then there is polycythemia, so there are more chances
You,
of
you know,
pulmonary
uh,
embolism, sir.
is all of you are satisfied with his answer?
Pulmonary
Zishan,
edema, sir.
I think you are going a little off track. So you can say very easily that these patients have some element of heart failure, and whenever there is heart failure, there can be pulmonary edema. You got my point, Zishan?
Got it, sir.
Yes, yes, thank you. So Zishan, agreed or no?
Yes, sir.
Because you answered in a complicated way. Your answer is not wrong, but try to be like polycythemia is something else. So polycythemia will have effect on one of the things what you were saying, pulmonary embolism. Okay, because there is polycythemia. So
Yes.
this is obesity, polycythemia. This is one of the factor for DVT. Sorry, this pulmonary embolism. Okay.
Yes, sir.
So this is related to in that way. And right heart failure will not cause pulmonary edema directly. Right heart failure will cause peripheral edema. Okay. There will be raised
Yes.
JVP. There will be congested liver. So this is going towards the other side. And when like so pulmonary edema is in like it will, you can explain it in slightly different way. Okay.
Yes, sir.
So, so these are the things which you can do just
Sir,
now.
can pulmonary hypertension lead to edema?
Pulmonary hypertension. Okay,
Experience
explain to me
patient with pulmonary hypertension, sir.
how pulmonary hypertension will develop pulmonary edema.
Sir, no, sir, I'm asking, sir. I'm not sure about this, sir.
No, no, you
I'm
tell.
asking.
Pulmonary hypertension will lead to pulmonary edema. Just Zishan, can you answer this?
Sir, I don't think so that pulmonary hypertension can lead to pulmonary edema. Pulmonary edema, sir. The main cause of pulmonary edema can be due to the left heart failure.
Left heart failure or
So
overload or
overload.
congestive heart failure. Okay,
Yes, sir.
the known now you got it.
Yes, sir. Yes, sir. Thank you.
Because try to make it very simple. Whenever there is problem in the lungs, initially, if it is purely lung pathology, it will affect the right side of heart. Okay. Left side of heart pathology, like valvular heart disease, like if patient has mitral stenosis, for example, there will be stasis. Now that pressure will going back. If acute overload situation occur, there will be pulmonary edema. But if it is chronic, then it will lead to pulmonary hypertension. Okay. So then pulmonary hypertension develop and it will leads to right heart failure. So these are interlinked things. So you just have to be understand because there are various types of pulmonary edema. One is negative pressure pulmonary edema. One is neurogenic pulmonary edema. Okay, one is cardiogenic pulmonary edema. So we are talking about cardiogenic pulmonary edema. Okay, because neurogenic and negative pressure is totally different. So they have nothing to do here. We are talking here about cardiogenic pulmonary edema. Okay, so this is how you should be understanding the situation. Okay, so up till now we just try to. Okay, so Zishan, can you explain some of the effects of smoking? Because smoking also
Uh,
is closely related, and in the exam when they are asking, they can ask you about this question, that what are the effects of smoking?
Sir, effects of smoking, starting from the airway ciliary function, they can damage the ciliary function of the airway, so decrease secretion of the mucus, so
Clearing,
increase chances of respiratory.
decrease
Yes, in
mucociliary clearance.
yes, sir.
Okay, so in stasis and infection. What else? There is increased
Mm,
nicotine level, there is carbon monoxide level increasing, or and what else?
uh, uh, increase and then can they can also due to increased carbon monoxide they can they are also leading cause of polycythemia, sir. So they can cause polycythemia, and they also decrease the oxygen carrying capacity of hemoglobin, sir. So decreased oxygen hemoglobin.
Oxygen carrying capacity, how it is related to smoking?
Sir, because it increased the carbon monoxide level. So the carbon monoxide are more affinity for Hb than oxygen. So
So use technical
they can
word.
indirectly affect
So it's leftward shift,
leftward shift. Yes.
shift of oxygen hemoglobin. So actually, oxygen carrying capacity is changed in a different way, that oxygen is not being utilized. Okay, so this is how you will explain.
Yes.
And usually this is the chart which you should be knowing. So 12 to 24 hours, if you stop it, so what will be the effects and what is the, so FE1 is decreased, oxygen carriage, that's as you explained, irritable upper airway. Okay, and both upper airway and lower airway. So you can say how it is. So this one ciliary function, as you said, stasis and infection, and increased closing capacity. So there is shunt. So in hypertension, so ischemia, ischemic heart disease. So they are like in that way. So this is what you should be knowing. So 12 to 24 hours, even if you stop it, so monoxide level and nicotine level will decrease. Okay, and then 2 to 10 days improvement in upper airway reactivity, possible increase in postoperative complication in what is 1 to 1 by 12.
So, 6 months, maybe so.
1 by 12 means 1 month, 5 to
1 month.
6, 5 to 6 month. So actually, what this is something which is important. If we stop it, so there are some increased chances of airway irritability at some time. Okay, so this is something you should be this period, possible increase in postoperative pulmonary complication in 1 month. So at least 5 to 6, just to say, it's not very clear, because some points, if you don't recall, they just slip out of your mind. It's not very clear. Just let us have a look somewhere else. Just a second. because this is what you should be. So the question is that why it in 1 month there are more chances of complication. I forgot it, so I will need to review. Just a second, please.
So serious
So
activity come after 6 weeks. The serious get activated, sir, if person
so that's
stops smoking.
So actually, this is because the mucociliary clearance will be halfway. Like irritation will be there, and mucoclearance is still not good. So that is the time where can be the where more chances of postoperative complication can occur. So this is if you want to stop it up to 6 weeks, or you immediately if you stop it for 24 hours, these effects you will come you will get. Okay, so this is something you should be knowing because they can ask you this point. Okay, so that as they have written here, these observations are in keeping with evidence that improvement in ciliary activity, small airway function, and sputum production takes some weeks to establish themselves, and also with the suggestion that there may be a beneficial irritant and presumably expectorant effect of cigarette smoke. Perverse through this observation seems studies suggesting the latter should be interpreted with caution due to inevitable methodical problems in determining smoking status and reason for stopping. They do not support the approach that it is not worth stopping within 2 months of the surgery. Okay. Improvement in upper airway reactivity can be anticipated after 48 hours cessation, although peak benefit is reached after 10 days. So you can say that you now what is the inference which I will explain to you, that you can say that if it is stopped for around 1 month, maybe chances of some in some patients the activity can be more. Okay, so if there is the like mucoclearance is still not fully resumed, so because of impaired mucociliary clearance and loss of this irritability function, there may patient is not able to cough out properly, because as it is written here that smoking is irritation is actually acting as an expectorant. Okay, so if this effect is decreased a little bit and mucociliary clearance is still not very good, so this can combine in resulting stasis. So you can say that not in all patient, but it is a possibility. So if you want to stop it, at least 6 weeks. Okay, otherwise if you just want to have quick effect, even 1 day or 1 week will still help you. Okay, so carbon monoxide levels will be decreased, nicotine level will be decreased. So you can have a look here. Okay, so like because it's such a important topic that you should have very clear concept about it, and because no exam will be finished without this topic. Okay, so that's what I just wanted to show you. Okay, so coming back, so up till now, what we have discussed is that COPD. What are the challenges in anesthesia care? We have to think about the preoperative status, that you will target the reversible component of asthma. You will try to give some antibiotics. You will try to give some steroids. You will do all these things to get some reversibility. And quantify, how can you quantify, Zishan? Like how you can say that patient is getting better by PEFR. Okay, you can just do a bedside peak expiratory flow rate, or in detail we can do pulmonary function tests. Okay, So there may be some improvement. So peak expiratory flow rate, you can just say this is 1 point. And when you are anesthetizing this patient, as I told you, that giving GA, if you are giving GA, you will avoid all the medications which can precipitate bronchospasm and histamine releasing medications. Okay. And you will anticipate some of the effects of the medication which the patient was taking, like tachycardia and hypokalemia. And these arrhythmias. If the COPD is prolonged and there is like a development of, because I will go back to the traditional points about COPD, that what is COPD, what is emphysema, what is chronic bronchitis. But practically, I went to the practical aspects first, and then we will see what else is left. Okay. So practically, any patient with COPD, if you are giving general anesthesia, you take care of the airway pressures. Take care of the airway pressures. Take care of the airway pressure. So your answer should be in COPD that in addition to standard 1 and standard 2 monitoring, we will carefully monitor the airway pressures. Okay. This your answer should be there. And then in the ventilation, you will say that maybe we need to have low respiratory rate and prolong expiratory time. Okay, because in this patient, because of air trapping, development of auto PEEP, so you might need to carefully use the use of PEEP, because extrinsic PEEP will be the treatment for the development for the auto PEEP being developed in these patients. Okay, so this is what you, and then again the same thing. If someone asks you regional versus GA, how will you answer this question, Zishan? As I mentioned to you, that you have to take care whether the patient can lie flat on the bed or no. Okay. So this is one thing.
Yes.
And if you have given, for example, epidural or spinal, it's not totally safe. Okay. Because why, how can you explain, Zishan?
Sir, because in epidural spinal, there could be, depending upon the level of block, there could be involvement of intercostal nerve blocks that can decrease in the deep breathing of the patient. So increase chances
Use
of
slightly more technical, that these patients are dependent on these muscles for the control of their breathing. Okay. Usually
yes.
we are not using these accessory muscles. Okay. So when we block the abdominal muscles, when we block the intercostal muscles, a patient can go in failure. Patient will not be able to breathe. Okay. So this is how, that's why never say that spinal is safe or epidural is safe. Never. You can have problem. Rather, if you give spinal or epidural, and it's blocking it, and the patient maybe before surgery, sorry, before giving this, patient may be adjusted to his situation, and now you have blocked, and now you will be in trouble. Same point with the MAC, with local anesthesia, because they can ask you this scenario with ophthalmology, they can ask you this scenario with COPD and end stage renal disease coming for creation of AV fistula. So same problem will occur if you give brachial plexus block. Okay. And now the patient has this phrenic nerve involvement. Okay. So now the diaphragm is blocked. So hemidiaphragm is blocked, and now the patient will be in trouble. Okay. So when you are thinking, this is very important point which you need to highlight. Okay. So you have to be very careful. You should try to use the techniques to avoid phrenic nerve blockade as much as possible. And how you can spare infraclavicular block will can be given if you are using coracoid technique under ultrasound, but the problem with infraclavicular block will be that there are chances of pneumothorax. So it's very it's a challenging thing to give. Axillary block will be a better choice. Okay, Zishan. So if you want
Yes.
to if you want to do AV fistula creation under brachial plexus block, axillary block will be a better choice, because if you give supraclavicular, there are high chances of involvement of phrenic nerve. It's difficult to spare it. Okay. And if you use this one infraclavicular block, yes, you can spare some of the problems, but there will be high chances of pneumothorax. Okay, because hyperinflated lungs. Okay. So and because in the scenario, why I am telling you these things, because rest of the things, in the exam they will be asking you in the scenarios these things, and these things are very important. So if they ask, because in ophthalmology, you need a patient to be lying flat, and sometimes it can create problem, patient will not be able to breathe, but you might need to give GA, general anesthesia, in that case. So they can trick you. And the use of regional anesthesia is spinal, epidural, even peripheral nerve blocks, and any nerve block in which involvement of intercostal muscles, involvement of this diaphragm is if gone, so that's a concern for you. That should be a concern for you. Okay. And development of autopsy, use of uh, lung protective sort of strategies, in a way that especially that you are avoiding high airway pressures. Okay. And like whatever optimization you can get before surgery, do it. Okay. So some theoretical questions. How much tidal volume and respiratory rate you have to keep in COPD? Dr. Sumera, you are asking a question which is a very diplomatic answer is needed. Usually it depends on the patient, but usually you try to have lower respiratory rate, higher this expiratory time, prolonged expiratory time, and tidal volume is dependent on, actually, because you should be doing pressure control. So you have to limit the pressure so that you are avoiding barotrauma, because it can lead to this. Just a second. I was about to open this, because here it is written nicely. So I will just show you. Yes. Okay. Okay, so as I was mentioning, this is a limited expiratory flow rate because of narrow airway narrowing result in next exhalation occurring before expiration of the previous breath is complete, and lead to breath stacking and air trapping and the development of intrinsic PEEP, as I told you. The elevation of intrathoracic pressure results in decreased systemic vascular resistance and may be transmitted to the pulmonary artery, raising pulmonary artery, vascular resistance, and lead to right heart stent, as we discussed. Along with direct pressure exerted on the heart by hyperinflated lungs, this explains the cardiovascular instability that commonly occurs. Other potential harmful effects of air trapping include pulmonary barotrauma, polytrauma, hypercapnia, and acidosis. One of the first indicator of air trapping may be slow filling of manual ventilator bags during induction of anesthesia. Once mechanical ventilation has begun, air trapping may be suggested by a capnography trace that does not reach a plateau, indicating continuing admixture of air from the dead space, reducing and expired concentration. Okay, it may also be possible to identify air trapping using the ventilator to show that expiratory flow rate. I am not very expert in this explanation, but you read it because I believe more on whatever I can explain extempore. So as this is the summary which I was telling you. More time for exhalation. This is one point. Application of PEEP. This is second point. And if the bronchospasm occurs, you have to treat it. Okay. So this is what I was telling you.
There is also one point that use the lowest FiO2 possible to keep the saturation between 88 to 92, because in COPD you don't have to give too much oxygen, as it can cause a disease effect in a patient with COPD.
Yes, because that is what is actually another because these points are we are missing. So we will try, because there are certain things. You don't need to give too much oxygen, FiO2, because a number of time they are dependent on hypoxia. Okay. So if you give too much oxygen intraoperatively, even so, what can happen that even post-operatively, if you give too much oxygen, maybe patient will go in failure. Okay. So you need to repeat. That's why what sort of oxygen mask you need to give? Use
Venturi, sir.
Venturi mask.
Venturi.
This is one thing.
Mark.
Yes. So another thing is that this one uh, this that what you were saying, that you will not that's why you can use this word of lung protective strategies, because lung protective strategies says what you will try manage the ventilation in a way that you protect the airway from barotrauma. This is one thing. You will have settlement on slightly low oxygen saturations, and you will permit a little bit of hypercapnia. Okay. And another thing is that hypercapnia, because they are settled to hypercapnia. So actually, if you wash out CO2, again, it will lead to respiratory failure. So because what
They will
happens in,
lose the respiratory drive.
sorry,
Respiratory drive, because the hypercapnia maintains the respiratory drive for them
no,
if you
no,
give them more amount of oxygen.
no, 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 no. I was about to say this, Bharat. So actually, thing is that, and in these patients, when usually the respiratory drive is through in normal patients, or like you can say, not a very chronic, dependent, like chronically, these patients which are having prolonged COPD. What happens that normally CO2 is the one which is driving the ventilation. Okay. But what happens if there is chronic hypercapnia? So actually the sensitivity to CO2 is decreased. So actually they are not responding normally. If we have that much CO2, normal, maybe 50, 55, they are normal. This is normal for them. Maybe if we develop, maybe we will go in carbon dioxide narcosis, but these patients will not. So, okay, so their sensitivity of ventilatory drive to CO2 is decreased, and actually they are dependent on hypoxic drive. So hypoxia is the one which is driving their ventilation. Okay, so not CO2. Actually, they are dependent on hypoxic drive, because CO2 is CO2 has become friend to the respiratory center. CO2 is not stimulating the respiration. Normally, what we do, even this is a old tested technique, that when we want to awaken the patient, we put the patient on spontaneous, and we keep we let the patient to retain CO2 a little bit, because we say that CO2 will stimulate the respiratory center. That's what all old anesthetists used to do. Maybe this is not a bookish technique, but this is old tested. I have, when I was 20 years ago, when I started anesthesia, I saw so many people doing it. Okay. So anyways, so this is traditionally what we do, and traditionally it happened. But in this patient, because CO2 is their friend, so CO2 is not affecting. So hypoxic drive is the one which is making the ventilation. Okay. So I hope you understand. Peep, unfortunately, Noon, you have asked me this question. I'm not very good in this topic, because there is another point which you need to understand, is about like how this, because I'm not very bad in these graphs, unfortunately. So I'm afraid only this one I have explained to you, that when patient is not able to expire. Okay. So there is a staking, and there is development of intrinsic PEEP, and treatment of intrinsic PEEP is extrinsic PEEP. How? I don't remember. Okay. So pardon me for
I
that.
will, I will suggest, sir. I will suggest.
If anyone knows about it, please, I will be very happy to explain, because I don't remember it how it the treatment is PEEP, but how maybe it is written the use of external is ventilated has theoretically benefits by keeping small airway open during a late exhalation, so potentially reducing intrinsic PEEP. How? I don't know. I don't remember. It has been suggested that if the values of applied PEEP are kept below IPEEP, there should be no significant increase in alveolar pressure, and so no worsening of cardiovascular effects, while hopefully attenuating intrinsic PEEP. Clinical studies addressing this topic are inconclusive, partly because measurement of intrinsic PEEP is difficult, but also because patient responses to extrinsic PEEP have been found to be unpredictable, particularly in terms of improving gas exchange. Okay. So unfortunately, this is a complicated topic. Okay. So whatever I know, I have explained to you. Okay. So, okay, few questions are left and then we will finish. How we will how will define COPD? What is COPD? Yes, Ishan.
Sir, it is a chronic lung disease in which characterized by there is a airflow chronic airflow limitation and which is not fully reversible, and it includes chronic bronchitis and emphysema. Sir,
Okay. So you can say like few words you are saying said rightly, but you will say that it's like a chronic inflammatory condition. Okay, in which because of repeated the basic thing is airway reactivity, and now because of airway reactivity and decreased mucociliary clearance, there is damage to airway. So either the elastic function is lost, so there is pulmonary dilatation as it appears in emphysema, and when there is excessive sputum production and excessive cough, okay, so that is a component which occurs in chronic bronchitis. So chronic bronchitis component and emphysematous component, there is no clear differentiation, because no patient will be having only chronic bronchitis or only emphysema. Usually they are inter both components are there in the same patient. The ultimate result is impaired because the respiratory membrane from where the gas exchange has to occur is damaged. So whenever this occurs, there is VQ mismatch. Okay, because there is patient is not able to have the proper gas exchange. So both COPD and emphysema result in this picture. Okay, so if the patient will have prominent emphysematous picture, what we say is pink puffers, because they have to puff, they have to purse their lips to develop some because their airway is collapsing, so they are not able to there is always already too much dilated and they are not able to, so they purse their lips to generate some pressure so that they are able to maintain their airway patency. Okay, so this is one point. And the blue bloaters, they are the of COPD, sorry, the of chronic bronchitis, in which there is a further definition of chronic bronchitis is there is cough in, I remember some of the word about it, that there is cough in most parts of months, like that. Am I right? Is it like
Three
this?
consecutive months for at least 2 consecutive years.
Yes. So I'm sorry,
Yes, sir.
I'm very bad in definitions. I understand the concept, and I am trying to tell you is that concept. Expiratory airflow limitation because a combination of small airway inflammation, that is obstructive bronchiolitis, and parenchymal destruction, which occurs in emphysema. Inflammation in small airways cause obstruction and air trapping, leading to dynamic hyperinflation, which adversely affect the VQ and mechanics of the respiratory muscles. In emphysema, the end result of inflammation is elastic breakdown and subsequent loss of alveolar structural integrity, leading to decreased gas transfer, reduction in pulmonary capillary bed, and further worsening of VQ matching. Okay, so VQ mismatch will occur because of lack of transfer and also reduction in pulmonary capillary bed. Okay, so further airway airflow limitation results from reduced parenchymal support of small airways. Often it is not possible to make clear distinction between two subtypes. Okay, that's what I was telling. So rest of the things we have discussed, usually they have a combination, and we discussed about, so induction, you will expect collapse not only because of heart failure, because of coexisting problems. So you have to use titrated induction. This is one thing. You will avoid increased airway pressures. Uh, Propofol, if you are using, you try, like if there is a component of heart failure, you have to be careful. Muscle relaxant, what you will be using, cisatracurium will be a better choice because it does not release histamine. Okay, but if you think about the use of reversal, so then sugammadex rocuronium combination is good because it will have a better recovery as compared to cisatracurium to be reversed by neostigmine glycopyrrolate combination. Okay, but you can use it. Analgesia techniques, rest of the things are okay. Uh, any block or anything which is affecting the respiratory mechanics, you have to be careful. Okay. What about fluid? Is there any problem of fluid therapy in these patients?
The judicious fluid, as these patients have chances to develop pulmonary edema if their CVS is involved. So
Okay.
we should give judicious fluid replacement.
Okay. What else? Anything else?
So it will be individualized depending upon the patient condition. We can say that individualize. If we can individualize the patient, see whether the patient has increased chances of at the risk of developing pulmonary edema. So we should keep it restrictive. But if the patient is not, then we can use fluid according to the.
Secondly, sir, because of tachypnea, as these patients are prone for this loss of water through evaporation because of this tachypnea, sir. So preload patient with fluid.
Okay. What about use of albumin? Albumin will help.
So it will
Yes,
prevent
sir.
exudatory fluid if the oncotic pressure gets raised because of this albumin. So interstitial chances of fluid to come in interstitium will be lesser.
Yes, because oncotic pressure, if it is good, this is one of the factor to reduce chances of pulmonary edema. So if you want to use albumin or any colloids will be a better choice as compared to crystalloid. Okay, but you can use it. That like fluid therapy is as Ishan was mentioning that you can have an individualized plan. Usually, if there is no heart failure, then you can give fluid because if you don't give proper fluid because they are having more chances of dehydration or low blood volume or viscosity if it is increased. That's also a factor for complications. Okay, so few points which are left is that any minimal invasive surgery will be a better choice, and um, like upper abdominal, because you should be knowing the the pulmonary risk factors. Okay, so low albumin is one of them. Upper abdominal surgery is another them. If the patient has pain, this will cause splinting. Already there is problem in removing the CO2, or there is already chances of infection. So if there is a splinting and breath holding, that will create further deterioration. Okay, so you have to be using the these are the things, because when they are asking you in the scenario, you have to think about these things and then you have to organize your answer. So don't forget to tell main points in the start. So from where the first question we started, that if someone is asking you about what are the anesthesia concerns in COPD, or if they are asking you in scenario that a patient with COPD is going for laparoscopic cholecystectomy, for example, so you have to tell in that way that you have to target, you will evaluate the patient on the basis of history, examination, and investigations, and you will see the severity. Okay, so this will be one thing. The other answer, the word should be you will target the reversible component and you will try to optimize as much as possible in the time permitted. So you will discuss with the surgeon how much time you will have and you will try to optimize as much as possible. This should be your answer. And then you can further tell that there are problems with reference to not only intraoperative management with reference to ventilation and these patients will be prone to have post-operative respiratory problems. So maybe this patient require post-operative high dependency unit, or maybe you are not able, if you are not able to extubate, maybe this patient needs this one post-operative ventilation. Okay, so rest of the things you will tell in an organized way, that I will use, in addition to standard 1, standard 2 monitoring, this will be the monitoring I require. Maybe I need to have a because I might need to do frequent ABGs. This is one thing. Or you might need to have a better hemodynamic control. So I might need to have intraarterial blood pressure monitoring. Okay. So this is how you can explain. And remember one thing, that the basic format of anesthesia, starting from evaluation, referral, optimization, and then the rest of the things will come: acid prophylaxis and enzolysis, and the induction, airway management, maintenance, monitoring, fluid, analgesia, and recovery. So fill. So if you want to fill acid prophylaxis, there is nothing special according to the scenario. Okay, and this one in Alillah. Endolysis, you need to give carefully. There is some problem in this. I don't know how it start opening these pages. Apology for that. So, endolysis will be careful, because if you give uh, too much sedation, this can cause what it can cause. It can cause this sedation, and it can cause respiratory failure. Okay. So investigation, we did not see ECG can have some element of right heart failure, strain pattern. These are the things. In X-ray, you can find emphysematous things. You can find some infection. You can find like any like this signs of increased cardiac shadow. So will have some findings in the X-ray. ECG, if there is element of heart failure and there is symptom, they might need to have echo. Okay. CT scan, or some other investigation related to lungs accordingly, if there is any indication, and PFTs. Okay. So preoperative ABGs. So you have to maintain the CO2 level. You have to maintain the preoperative thing. It will be better, because if you overcorrect CO2 or you give too much oxygen, it can lead to failure. So CBC will have high, hematocrit will be high. So you have to give adequate fluid. You need not to keep the patient too much dry. This thing, and rest of the things you can see, you can find in WBC, there may be some infection. Okay. So electrolytes with reference to use of diuretics and beta agonists. Okay. What else is left? If there is involvement of overload, sorry, right heart failure, so maybe in some involvement of liver. Otherwise, rest of the things. Renal failure can occur because of steroids, because of if there is hypertension. So you will just do liver function and renal function accordingly if needed. Electrolytes, CBC, chest X-ray, ECG, echo if needed, pulmonary function test. Okay. So I hope I have tried to cover this topic, which is a very, very common topic to be asked. And Zishan, if this case comes in long case, same approach you should be there. Okay. The
Yes, sir.
rest of the inspection and palpation and percussion and auscultation and involvement of liver. So don't forget to do this hepatojugular reflex in this patient, and you will measure the diameter. Okay. Then you will go from the side and have a look on the chest, and you will go to the foot side and have a look, all the bloody dramas. Okay. And then you will do
Yes,
the lung excursion. You will see inspiration, expiration, and what else you can find? Problem in the auscultation. You can have some added sounds. You can have all the respiratory findings you can have. Okay. And
Yes,
what else? So you just explain in that way and you think about it and then be very simple. So inspection, palpation, percussion, auscultation, and then you will tell about the investigations. Okay. And as I told you. So this is a question. If you understand, you will be able to answer in a proper way. Okay. So I will stop here
yes,
and inshallah we will continue. I hope I try to, I try to explain as much as possible. It's a difficult topic. Have a look on the findings on the X-ray because that will come in your talks, whosoever is appearing in the talks as well. Okay. So thank you very much, all of you,
Thank
for
you.
spread. A special thanks to my dear friend Hamad, because Hamad is our chief guest. He is appearing in the exam, and so he was not coming. So all these classes right now is because special thanks to Zishan, because I'm only doing on the request of Zishan because only Zishan seems to be interested. Okay, so thank you, Zishan, and Hamza Noon is my champion. So champ is there. Okay. So thank you very much, all of you. Inshallah.
Thank you. Thank you. Thanks for your kind,
Tomorrow,
sir.
tomorrow I have on call. If I get free, I will try to take a class. Otherwise, day after tomorrow. Okay.
okay, sir.
Okay,
Yes, sir. Thank
Zishan.
you.
Thank you. Bye bye. Assalamu alaikum.
Thank you.